This is a patient referred with an IC8 lens. She had an attempted YAG laser, but the lens was pitted and there was still significant opacity. She has count fingers vision in this eye and was actually unhappy with her vision with this eye prior to the PC opacity developing. She really did not have the range of vision or quality of vision she wanted. So we've made a decision to remove this IC8 lens and, if possible, replace with an Envista multifocal lens in the capsular bag. So here I'm making my paracentesis. I'm injecting first dispersive, then cohesive viscoelastic. And now using a LASIK cannula, I'm going to try to reopen the capsular bag and remove this lens. And I really don't know what the status exactly is of the posterior capsule behind this lens because I can't really see it that well with the ring in the IC8 lens. So here I've completely reopened the capsular bag, separated the anterior and posterior capsule to the periphery using visco dissection. I'm going to create a incision that's slightly larger than 2.75 millimeters using a keratome. And the lens really comes out of the capsular bag very easily. There's no notch or anything to create an area of restriction, so this just slides right out very nicely. And now I've got the lens in the anterior chamber. I can go ahead and grab it and cut it in half, and you can see that you can cut right through this ring very easily. It just cuts like a normal IOL. So here I've completely bisected the lens, and I'm going to take each half out independently. We grab the first half, pull this out, and grab the second half and pull it out. And it's pretty tight. That's why I made the incision a little larger than I normally do. I made it about 3 millimeters, but this is a bit of a tight pull. It takes more than one attempt. And now I can see that there is a hole in the posterior capsule. And I'm sweeping to see if there's any vitreous, and I don't see any vitreous. So my first thought is that I want to enlarge this, so I inject a little cohesive viscoelastic over this hole and then a little bit actually under it to equilibrate the pressure. And then I'm going to go in with a 23 gauge disposable vitreoretinal microscissor and try to create an opening or a nip in the capsule here so I can tear it a bit. But this posterior capsule, because of the fibrosis, is a bit rubbery. So here I'm going ahead and cutting this a bit. And then when I achieve a little flap, I'm going to inject some viscoelastic and try to tear this. And it really tears. It's a little bit rubbery and it's a little tricky to tear, but I am able to enlarge it a bit. And once that's done, I'm going to inject a little cohesive viscoelastic into the capsular bag and go ahead and place the Envista Envy lens, the trifocal lens, in the capsular bag. And this unfolds nicely, and I'm going to then tuck it under the anterior capsule and rotate this into position. The lens looks very stable. It's well centered. And once this is done, I go ahead and remove viscoelastic from the anterior chamber. And as I do this, I'm looking at the lens, and I do see that there's significant anterior vitreous debris, and I'm also concerned that there might be some vitreous trapped behind the IOL and between the posterior capsule and the IOL, causing some traction. I also wanted to enlarge the rexus opening, so I made a decision to place a couple of pars plana trocars to clean up the anterior vitreous and enlarge the rexus opening using a pars plana approach. So I've placed my 2 trocars, and now I'm cleaning up the vitreous and the floaters that are liberated by what I've done, and expanding the posterior capsule opening so I won't have to do further YAG that might liberate even more floaters. I can also make sure by doing this that there's no vitreous trap between the posterior capsule and the IOL or herniating into the anterior chamber, and that will eliminate any risk of vitreous traction. I'll move my infusion and vitrector into the anterior chamber to remove viscoelastic. Once this is done, I finish the vitrectomy with the anterior infusion, and the case is completed. The rexus opening is larger. The vitreous has been cleaned up. The eye is firm now. I'm going to go ahead and take out these trocars, and the case is completed. The next day in the office, the lens was perfectly centered. She was 20/25 uncorrected. This lens gave her the quality of vision and range of vision that she was seeking. So all's well that ends well. Thank you for your attention to this case.